Hope Cook here with Dermcast TV. Today we have Dr. Candrice Heath. She's located in Philadelphia and serves as professor at Temple University. And she's triple board certified in dermatology, pediatric dermatology, and pediatrics. Welcome, Dr. Heath.
Thank you so much. Well, soon I will be a professor at some point, but I'm an assistant professor of dermatology right now, and I'm looking forward to staying on and advancing through the ranks.
And Dr. Heath specializes in skin of color, so I'm excited to hear more about that.
Yes.
What do you hope that our listeners get from our conversation today?
Well, I hope they're able to have some take-home points, some of the things that they can incorporate in their own practice as it relates to pediatric dermatology or skin of color, and also just really push them to maybe have some conversations that they're uncomfortable with to help their patients have a better interaction in the exam room.
Yes, because I've realized that red does not look red on every skin type.
It does not. In fact, in patients with brown skin tones, definitely you can actually see violaceous or purple-like color. You may not see erythema at all. So if the textbook is telling you in order to diagnose this condition, the patient will be red or have a lot of erythema on the skin, you may miss it.
Yes, especially if it's faint.
Yeah, absolutely. Absolutely.
And I've also noticed hyperpigmentation can look different, and it can be a bigger concern than I think it is. So I've had patients come in and their only complaint is dark spots.
Super common complaint for sure. So it's our job to really tell the patient, yes, we see the hyperpigmentation. We know how much it affects you, but we also have to treat the underlying problem that's causing the hyperpigmentation in the first place. And then even including some things in the regimen to help with hyperpigmentation as well. And verbalizing that you are doing that can be very helpful.
Yes, so if they know they're headed in the right direction, you're going to fade out those spots, then it makes them more compliant, I would guess.
Absolutely, absolutely.
What is one of your biggest pet peeves when patients get sent to you from another provider? Are there any pet peeves that you've accumulated over the years?
I mean, sometimes, we think about, it's like, oh my goodness, why did this patient do this? Or why didn't the, provider, clinician, why didn't they do this first? And my take on it has been because maybe they don't know. They don't know that before sending the patient, maybe they need to try a higher level of topical steroid to help to maintain this. Maybe they were unfamiliar with the patient's hairstyle and they come to me for a hair loss concern, for an example, but they have other extensions and things in the scalp that I cannot actually visualize the scalp. So I really take it as a teaching moment to teach the patients, and also doing more and more lectures nationally so that we know how to prepare our patients when we refer them to subspecialized care.
Yes, and you've written articles on how to treat patients with, I guess you would call it
tightly coiled hair. I call it tightly coiled hair. And I think people understand that. Because when we get into this discussion about race and ethnicity and all of this, it gets a little crazy, because if someone turns around, if 100 people turn around that have curly hair, and then you ask them, well, what is your ethnicity? Or where do you, they're going to check all different types of boxes. So I like to go back to the biology. So if you have tightly coiled hair and it's more prone to dryness, then if you have that patient in front of you, I like to talk about tips to take care of them, take care of that type of hair, and help them to still have confidence in you as their clinician.
And it'll also make a difference in the vehicle you use, right?
Absolutely. So, as someone who has tightly coiled hair, we can be very creative about what we do with our hair. So one day it may be completely straight because we just straightened it briefly with heat. So if I show up in your office and you say, oh, you have seborrheic dermatitis, I'm going to give you a liquid-based medication. And then I start to use that medication in my scalp, and all of a sudden my roots are really curly and the ends of my hair are really straight. Then I'm going to be upset because I spent a lot of money trying to at least have my hair straight for the next 1 to 2 weeks, and that's kind of ruined. So as I tell my residents that I train and my PA students, ask the patient. If you are not sure, I say present the options to them.
Yes.
And I've written about this very much, so people can definitely look in the literature in PubMed and find these articles, but really asking the patient what they prefer. Do you prefer this in a liquid, an ointment, a white cream? So really kind of giving them the options can help. And then based on some of the things that your patients are saying over and over again, maybe sometimes then you'll be able to say, would you like this? I thought you were going to say that you preferred that. Yes.
That makes so much sense.
Yes.
And I think what you're saying too is just don't be afraid to ask the patients.
Right.
Don't be afraid to say, this is a white cream. It's going to be, it's a white cream.
How does it feel? Or all of that. And so that way they have a part in their own healthcare. And that's something important that I stress with my patients. I don't want them to leave the office and say, oh, I have a skin problem, or I have something with my skin or something wrong with my hair. I want them to know exactly what their diagnosis is, because it is empowering, because now they're part of their own healthcare.
That does make sense. I also heard you talking about how hyperpigmentation can affect your perception of yourself, and parents get really upset when their kids have dark spots sometimes, and they'll Google, what's causing it. And can you talk a little bit about that?
Oh, absolutely. So patients often will bring their child to see you, but they are also bringing all of their life experiences as well. And I've talked about this a lot nationally, and it really does make sense once people hear my explanation. So you may be seeing a child in front of you that has a few dark spots, and the parent is really flipping out about this. And it's because the parent themselves, especially if they have brown skin, probably have dark spots that have lasted for months and years. That's really distressing. And then you compare that clinical interaction to a lot of the papers that have come out about quality of life and people who have hyperpigmentation. And you can see that post-inflammatory hyperpigmentation is really at the top of that list for impacting quality of life. So now you put it all together. So you're not just taking care of a child with 2 dark spots. You're taking care of a lifetime of problems from the parent, and they're trying to prevent that from happening in their child.
Yes, it is a big deal.
It is.
Yeah. So what about, you were mentioning hair too, and how, a lot of the braiding techniques can really cause traction on the roots. What do you tell parents when they're like, no, but it's so cute and I want to do the little braids?
Right. So I definitely, talk to parents, and I try to tell them that, this is your child. You can do whatever you want with your child, but I definitely want you to do things in moderation. We want your child to have edges or frontal hairline for their entire life. So the time is now to really try to protect that. And I think that investment in the future conversation does go a long way. So I have written about that recently. There's a journal publication in Cutis about that, so that you can hear my formula for how to actually speak to patients who have traction alopecia, even if you don't have the same type of hair they do. If you tried to kind of go into this conversation before, and the patient ends up looking at you like, what? Like, what did just happen? This article will guide you in that direction. And we also talked about that in one of the recent lectures.
I love that, because if you don't have the right terminology and you're stumbling over your words, and I guess they see that you're trying, but it makes a bigger difference if you know how to have that conversation.
Right. And it is about really about cultural humility. So that is something that I've been writing about in the literature, to say, okay, we're not going to be perfect, but if we give each other a little wiggle room, if I know that you are trying to learn more about my preferences and my cultural things, instead of just acting like it doesn't exist and just, practicing as normal, that goes a long way. And so I'm glad that there's this cultural humility that has come out. The old term was cultural competence. And I really still believe that we should be putting out our physicians, dermatologists, PA students with cultural competence. That should be the goal, meaning that we all get everybody. But in reality, we're all going to be learning for a lifetime about everyone's culture and staying up. But if we both remain if we both have this cultural humility, then it will present an opportunity for learning for a lifetime.
Yes. And if you can laugh at yourself, I remember telling a patient to use ketoconazole shampoo every other day, 3 times a week. And she's like, I don't wash my hair 3 times a week. And, we had to have that conversation, and she explained about her hair routine, and I learned.
Yeah. And that is, I'm glad that you took the time and the patient, you all had that discussion, because sometimes patients don't say anything and then they leave and they don't do anything. And then they tell other people that, oh, it's just don't even worry about going to a dermatology office. They don't really understand us anyway. So we don't want that to happen. So again, you can use the technique of, well, these are the medication options. Which one would fit best in your hair care routine? That's it.
Yes.
That can open a conversation, and then you can develop a treatment plan for your patient that they'll actually use.
Treat the patient, not the condition.
Right. Exactly.
Yeah.
Exactly.
Thank you so much. This has been
welcome.
So enlightening. And y'all read that article that she mentioned.
There's more than one article, actually.
Yes, there are quite a few articles, and more to come, I hope.
Yes, definitely more to come.
Thank you, Dr. Heath.
Thank you so much for having me.
Yeah.